Thank you very much. I was just saying to Bernadette then, us lawyers stick together. I know what it's like in those courtrooms where you're going, where is that piece of paper that I need? I was sitting as the solicitor and handing it to the barrister, so I know. So thank you very much to everyone for the opportunity to be here today. Thank you in particular for the welcome to country. I found that such a grounding moment, and I think the opportunity to realise we truly are in this together as all Australians as we grapple with the issues around suicide prevention. So I would like to begin by acknowledging the traditional owners of the land upon which we're meeting today, the Ngunnawal people here in Canberra, and for those online, for the traditional custodians of the lands upon which you are joining us, and to pay my respects to their elders past, present and future. I would also like to pay my respects to two other significant groups. Firstly, to all serving members in the Australian Defence Force and to veterans, I pay my respects. As the daughter of a man who committed the whole of his career to serving in the Royal Australian Navy, I share that experience, and I share in particular the experience of the mental health impacts that can arise as a consequence of those service years. I also want to pay my respects to all who know the reality of mental health and suicide. You might have noticed today that the title of my address is Compassion First. In the context of veterans and serving personnel, this overarching theme is, I believe, critical to build a better, more connected approach, and in fact, to try to achieve what is the theme of today's symposium and tomorrow's symposium: prevention through understanding. I'll talk about compassion first through the lens of the approach we've taken in the task force for the suicide prevention advice we've provided to the Prime Minister, and also in particular the evidence-based research we use to achieve a better, more connected way going forward. Over the course of today and tomorrow, though, please let me remind you that these are difficult subjects we're talking about, and if you do need some support, reach out. So I think probably the best place to start is actually not with my suicide prevention hat on, but the work we do in the National Mental Health Commission. Now, I just wanted to use this as a brief entry point because, as Bern has said, the reality of mental health challenges is a very real one, particularly for those who make the transition out of active service into vets. It is an absolute reality. In the Commission, we take a very comprehensive approach to what it means to address somebody's mental health. We talk about the importance of supporting somebody to be able to live a contributory life, and the importance of supporting their mental health on that journey. There are 5 aspects that we think are absolutely key to being able to be mentally healthy. You need to be able to thrive, not just survive. And I think for many who transition from active service, that can be a challenge. How do I thrive in a new environment? We need to ensure effective support, care and treatment, and the emphasis there is on effective. I think one of the particular challenges when looking at any issues around mental health and then across into suicide prevention is effective means it connects with the person. Many have heard me say previously that when you're talking about physical health, if you've got a broken arm, you can hold it out, you can see it. When it comes to mental health, when it comes to challenges around suicide ideation and suicidal behaviour, it is very personal, and it needs to be put into a language by that person and communicated to someone who's safe, and you then need to find effective ways of dealing with it. Effective not to the treatment provider, effective to the person receiving. Connection to family, friends, community and culture is a critical part of going forward. Again, when I reflect on the experience of our family and that transition time and that sense of, to his last days, my father identified himself as part of the defence family, that sense of connection. It never left him. It was integral. That has to be incorporated in any approach to mental health, wellbeing, suicide prevention for serving personnel and vets. Something meaningful to do, something that I feel I can contribute, again, really critical, and being able to feel safe, secure, and stable. The only way we can look at this, I think, in a mental health system perspective is it's a whole of system approach, but most importantly, it's a whole of life approach. So, very quickly, a little bit of background, just scooting through. Was appointed as the National Suicide Prevention Advisor in July 2019 with an 18-month time frame. Effectively to do two things. Firstly was to do a quick initial findings which were delivered in November of 2019. What are we doing, and are there any immediate things we should do a bit better? But the primary purpose of the appointment for this particular role, and I think it's one that leads itself very well into being amplified through the appointment of Bern and then the work of the Commission in this specific area, was the Prime Minister saying, would it make a difference if, as First Minister, opening up all of the levers of government, would that make a difference to our ability to reduce the number of suicides? That was a question with inquiry. And I'll lead you through what we found over the course of those 18 months. But one of the first commitments that we made when we were approaching this was to say, and I guess this is partly where my learned experience in terms of mental health and working with it over the last 15 years has been so critical, which is don't make the assumption that I understand it. When I was working in the area of eating disorders, it's an incredibly complex area, which is often defined by the behaviours somebody does. To actually understand that, to advocate for it, I needed to go inside that, and the only way I could effectively do that really was to listen. So that was the approach that we took quite consciously from get-go with the task force and the expert advisory group that I had working with us. It was to say we really need to listen to lived experience. And we broke it into two clear cohorts. And I think this was a critical learning during the course of the work we did, was to say, recognise there are two very legitimate streams of lived experience, and both are critical for suicide prevention. One is those who have gone through the reality of suicidal ideation, behaviour, distress and attempts. There is much we need to learn from those people. There is also a critical voice from families, friends, carers who are bereaved by suicide. Their experience is also critical, and I think one of the seismic moments actually was sitting with our expert advisory group where we have representatives of people with lived experience from both sides. And we presented them with some of the research findings we had, and they themselves identified, you need to ask both of us because we have different views and both are critical to understanding it. We certainly heard through Compassion First that the trauma that results in somebody getting to that point of distress starts frequently much, much earlier. And I think that is really important for us to understand that. It is a sense of cumulative pain, often of disadvantage. Importantly, I think for ourselves, points of disconnection, which can be associated with change. It's really important, we are told through people with a lived experience, that when they make that approach, when they come to us, when, as Bern says, people come and share their stories, that they are met with a compassionate approach, hence the title, Compassion. And compassion is the real sense of, I want to understand and I want to empathise, not just that I want to hear. In fact, one of the things that we heard that was most challenging for people who had gone through suicidal distress and crisis was the fact that they were problematised. They were made into medical problems that needed to be fixed. And yes, that is the presenting acuity at that point of distress, but it certainly does not explain or address the challenges that have gone into reaching that point. it became obvious to us that we did need to look at a much earlier intervention. I think if I have a landing point with the 18 months, it's effectively to say what has been happening over the last few years in terms of clinical interventions can be done better, but there's quite a lot happening in that space. But that is when somebody is in suicidal crisis. If we truly want to address suicide prevention, we need to go upstream. And so I think one of the most important early learnings, if you like, observations or call to arms within myself, was to say we are leaving it too late if all we look at is how do we prevent deaths. We must prevent attempts. We don't want anybody to get to the point where their sense, as Bern has said, of hopelessness and despair is such that they are attempting. So yes, let's get those deaths down, but let's actually start with getting attempts down. And one of the most critical things we need to do is to actually get some sort of standardisation as to what is an attempt. Out there in the whole of Australia, the definition of this is a coding issue when somebody is presented into an emergency department or a hospital setting. That's not, and that has got so much subjectivity to it. And not everybody who's attempted ends up in a medical hospital emergency situation. We've actually got to address that critical issue so we know what we're talking about. So, I'm in an interesting position at the moment where the final advice has gone to the Prime Minister. It went just before Christmas. That has not been made public. But what I feel very comfortable to talk about, and I'll give you a hint here, I'm effectively, in substance, probably talking about the final advice because the way we structured this was that the interim advice, which was made public by the Prime Minister on the 16th of November, and he did it in conjunction with the Productivity Commission on mental health reform that we needed, was put together in a way that it framed what we called in-principle recommendations. It was a distillation down of in-principle recommendations. In accordance with the process we'd taken with the whole task force work, we had a process of consultation. So we formulated those in-principle recommendations and they were actually done and dusted by about July. So in the period July through to the end of November, we were in pretty close consultation with jurisdictions and other stakeholders in order to really test those out. And there was refinement in the final advice, but not substantive change. So being able to talk quite publicly about the interim advice, we structured it through the lens of 3 individual reports, each of which can be read separately, but obviously, as goes with any reporting structure, you want to try and lead with the whole first. But what was most critical for us was that we put right up front our Compassion First report. And I'll speak to that in another couple of slides, but the Compassion First report was absolutely grounding in let us be inquisitive and ask. Let us not assume. So it was based on lived experience. We then formulated our interim advice, and by the time we'd got to doing the interim advice, which was really effectively in mid-2020, we were done and dusted with questioning, should we do whole of government? And we were right in that space of, yes, we are doing whole of government, so what the heck do we do to actually affect that? It's one of those classic ones which is easy to say and so darn difficult to do. Now, why did we need whole of government? If you look at it from that perspective of we've done quite a lot in the health portfolio around clinical interventions, but the reality is that we needed to move upstream and do true prevention, which means addressing those things which in a cumulative way result in suicidal distress for people. Now, if you have something in that space, in most instances, mental health services can't actually solve that problem. They can certainly provide the supports that somebody needs as they feel that enhanced or increased psychological distress. But if it's an unemployment issue, if it's a breakdown of family relationship issue, if it's a loss of identity issue, if it is something pertinent to serving in the forces or transitioning out, that's not a mental health expertise. that actually is a very pragmatic, who are the experts who can address and solve that issue. So let mental health support, but let the experts who can fix that unemployment issue or that family crisis step in and do it. And as soon as you get to that point, you say, actually, we have to move this out of health. It has to be whole of government. So our interim advice was really talking about what does that mean in terms of data, in terms of approaches, in terms of where we go. Shifting the focus, which was the third of those reports, was recognising the fact that as soon as we say we've got to move across into the justice area, or we've got to move across into homeless areas, or we've got to move across into infrastructure area, we can't assume any understanding or expertise around suicide. That's not their area of expertise. So what we tried to do in shifting the focus was to bring into a very distilled way a framework which tried to shape and explain suicidal behaviour. Again, through the lens of lived experience, through the lens of expert research and expertise, to actually explain what suicidal behaviour is, to link it across as to why it was therefore important for those in different portfolios to actually take this on and to understand what they could do. And then finally, we thought we would put in there a decision-making tool, something that could actually help portfolios to work that through. So that was kind of the way that we structured all of those. And I think that landing point was to say, if you're going to do whole of government, as soon as you get into whole of government, you get into how does this portfolio deal with this portfolio, deal with this portfolio. The Prime Minister, when I presented the final advice, said, Chris, I think actually what you're talking about here is not just whole of government, but whole of governments. Because he said, actually, if we're making it whole of governments and we need a national approach, then we need to work out how do we also link in those things which are done by the different jurisdictions. So, voices of lived experience, they are critical. I've spoken about the importance of those two cohorts. I think a compassion-first approach, what does that actually really mean? I'm often asked this question, yes, but what does it mean, Chris? How do you actually put lived experience into things? I think when you're looking at this in terms of policy formulation, policy responses, and then service responses, you actually do have to bring that expertise to the table. Now, I know that Gwen is going to be talking a little bit about the importance of co-design, a really kind of clunky phrase or one that we often use. Bringing lived experience to the table, you have a number of different choices as to how you can do it. There is tremendous value in stories. There's tremendous values in hearing what has worked for somebody, what hasn't worked for somebody. But there's also a very rich vein of information which is critical to extract, takes time to extract, and takes effort to extract. And that is what is the thematic reality that's coming through from all of those stories. That's one of the most critical things we can do. And I think it is when you can draw those thematic analysis through that you can then start to say, how can we actually make a difference in how we shape that service? What does that mean in terms of the number of people that are in that workforce? What does it mean about the types of disciplines that are in the workforce developing that service? What does it mean in terms of our outreach components that we've got to build into that service to reach people, because these are the barriers? They're the kind of questions that you've really got to look at in terms of trying to understand how do you make a policy different. The second thing that I think is incredibly important when you're looking at what voices of lived experience tell us is what I call the connected, compassionate, collaborative approach. The three kind of C's. Compassionate, I've talked about. One of our challenges is, can you actually instill compassion in people? Because if we need a compassionate approach, what does that actually mean for frontline people? What does it mean for those where stigma still exists, not only out there in the big, broad Australian community, but in our health services and our other services? What does it mean? How do you do that? How do you make someone compassionate? I think we've got to grapple with that. We've got to grapple with connected services. If you are somebody who's in distress, you don't want to have to navigate it yourself and try and find where you need it to go. You need to be connected and you need to be collaborative. That is challenging, sufficiently challenging when you're looking at one portfolio of health. It is extraordinarily challenging when you look at whole of government. I think I'll move on here to the next slide and actually talk you through what we found in Compassion First. So Compassion First taught us many things. It taught us that, and I think I've just had a disconnect, it's all right, I'll just talk to the slides. So the way we actually structured the Compassion First report is we worked with close to 2,000 Australians who had reached that point of suicidal distress that for many resulted in an attempt. So if we had tried to approach those who had had suicidal ideation, frighteningly, that would be a very, very significant number of us. So we went to those who had gone through that and we asked them two very key questions. One was, what were those things which really impacted or caused you, with hindsight, to reach that point? And then, what was your experience of services during that period when the crisis was building, at the time of crisis and following it? I have to say, there is no one-dimensional answer at all. It took a lot of work, but I think that is the most critical thing to say. The most critical thing to say is that what was experienced by one person is not necessarily experienced by another. But we weren't going to give up at that point. We did try and do that thematic analysis. And one of the interesting things I think that emerged for me as we were looking at it is I think I could probably break it down into three components. And if you're interested in reading the Compassion First report, there's actually 5 themed journeys that we did a light touch on to actually see if we can start to get some categorisation around this. They are a light touch because, as I say, the reality is every person's story is different. But if we don't try that themed approach, we're not then going to be able to say what are some of those critical junctures where we need to go and address 2 really critical questions. First question is, are there any lead indicators for when somebody is moving from ideation to intent? Because when somebody's moving from ideation to intent, they've made a critical transition. What are some indicators of that? The second is, what are the indicators when somebody is moving from intent into actual distress? When does that tipping point happen? And what can we show about that? After 18 months, I still don't have those answers. I think that's a key area where research needs to go. But we do know 3 key things. We know that for the vast majority of people who are going through suicide or get to the point of suicidal distress, suicidal crisis, it has begun much earlier. It is cumulative, as I said. It is accumulation of trauma. It is accumulation of pain. It is accumulation of distress. And that is an absolutely important thing. There tends to be something critical that will happen. And it might be more than one thing. It could be, if I take a generic one, and we're in a time when still 3/4 of those we lose to suicide are men. But I also note with interest, and this is interest, Bern, in your statistic about the increased deaths for women who have transitioned out. One of the most disturbing things at the moment is if you look at the last 10 years trajectory, the number of women who are attempting is significantly increasing. So what is happening? There will be a point of some sort of crisis. It could be losing your job. It could be, and often is, accompanied by a breakdown in significant family relationships. It could be, and I think this is highly pertinent for yourselves, a key life transition point, moving into ex-service. And it is, so it's those 2 things, and it is usually accompanied by an increase in a risk behaviour. It might be, I would not say it is just use of alcohol. I think that is too simplistic, too one-dimensional. It is a marked increase in a risk behaviour, whatever that may be for the person. I think another couple of things that we heard from the Compassion First, if I look at this slide, is that one of needing to have some assistance to navigate through the system when things are not working well. We need to bring family, friends and carers in on this journey. It's, as I've just said, it is so difficult to know when the point of crisis is being experienced. But I think one of the most disturbing stories I heard, and this is not a vet's story, it is a story of a mother who was a carer, who had a daughter who was in her late 20s, who had been hospitalised for 3 months following a suicide attempt. Mum and daughter were very close. Thankfully, what that meant was that the daughter felt very comfortable with her mother being across her medical records and in fact going to some of her sessions with her psychiatrist and psychologist. But the mother this evening, it was just before Christmas of 2019, was absolutely distraught because her daughter had just been discharged out of hospital and was in her care. And they'd gone to the psychiatrist, and the psychiatrist said to her daughter, "Do you have a plan? Do you intend?" Now, the daughter, out of a true sense of care for her mother, actually didn't want her mother to hear the details, so asked her mother to leave the room. 30 minutes later, the mother was asked back in, and nothing could be disclosed. So daughter went home with her mother knowing, well, I think I can probably guess she's got an intent, she's got a plan. What the heck do I do about that? And that was the reality not only for that family, but for too many families. What are we actually doing here? Because it is not appropriate to say we are just going to be a service provider through our psychologists, our psychiatrists or other support services. The reality is 24/7, somebody at risk is living with family members. They need to not only be supported through that, they need to be skilled, they need to understand. What do? We must bring them in, and that is critical. There's a critical learning out of that Compassion First report. So, what do we need? I'm actually calling it a seismic shift. We actually need a seismic shift where we bring together those different components, which is going to enable us to actually do things differently, do things earlier, and do things in a way that actually brings in the support of family and caregivers. I think two things that I would talk to from here. I've mentioned already the targeted distress interventions. It's actually finding those touch points and saying, before somebody has actually moved to suicidal crisis, what are we in a very practical way doing to address those distresses? And I would encourage you from a defence and veterans perspective to be very specific about that. One of the things that we've looked at in our reporting is to say there is not only merit but an imperative in bringing the consideration of our responses down to identify what we call population groups. I hate that phrase in a sense, but it's a necessary kind of label or necessary thing we need to use. And effectively the way we define that is to say, are there groupings of Australians who, because of certain attributes they share, put them at risk in a way that helps us identify where we can target a response. So we have to approach services for men. 3/4 of our deaths by suicide are for men. We have to approach it for our young people. We have to approach it for our Indigenous people, and they need to be the ones to find the answers. And I think actually, I'm going to press pause button and say this, it brings us back to lived experience. In each of these population groups, we need to understand from them what are those things which you share in common as being risk factors and how can we best help. Our LGBTQI+ community is at significant risk, and our vets and serving personnel. And yes, it appears that whilst a serving person, you might have some protective factors in there, that doesn't translate to when you transition. So I think it is really critical that we look at those distress intervention points and we say, what can we practically do to address those issues before they take off? And the second thing we need to do is to actually change the way we have this conversation and bring people into what we're doing. So I think this really sums up what we decided. Now, interestingly, when I was putting this together first, my starting point was to say, what are the key shifts we need to do? And it was somebody with lived experience who said to me, you got it around the wrong way, Chris. And I thought, yes, I have. Because they said, unless you've got the appropriate authorising environment to make changes, it doesn't matter what you call the shifts, they're not going to happen. So the 4 key components to the enablers is leadership and governance. Now, at a whole of government, so if I go back into the work that we were doing in our task force, which I think then dovetails across into the expanded work that Bern can be doing in her interim role and hopefully then into the full commissioner role. Leadership and governance. Now, I'm firmly of the view that if we do need to open up the whole of government in any jurisdiction and the whole of governments in a national approach, you must have the authorisation of your First Ministers. It made a real difference that as I was going out and talking to different portfolios, I was doing it with the imprimatur of the Prime Minister. If I'd done it with my National Mental Health Commission hat on, where I report to Greg Hunt, our Federal Health Minister, he could have encouraged his colleagues to speak to me. He couldn't require them. And that is a fundamental difference. So whether or not it is done by First Ministers, it must be authorised, owned, monitored, measured and reported on by First Ministers. Second, you've heard me say, and I'm not going to back away from repeating this and repeating it and repeating it, please think compassion, lived experience, knowledge and insight. There is nothing worse than getting a service just wrong. And you get it just wrong if it doesn't connect with the person. So get that insight in and get it right. Data and evidence to drive outcomes. Yes, there has been a lot that's been done to actually improve the reporting of suicide deaths. I think there's a lot more to be done, and Bern and I have touched on this a little bit in terms of conversations with our colleagues at the AIHW as to how we can even sharpen that a little bit further. I think one of the significant advantages of the work that Bern can do, and how good to hear that these powers will be enduring, is that you are a defined family. And that in terms of being able to identify what data do we need, how do we collect it, and how do we need to get that authorising environment right, is a real opportunity. And I would encourage everyone to really use that. As I say, my first priority, I think, when it comes to data, is to try at a national level to clean up this issue of how can we standardise what is a suicide attempt, and then to start getting those reported and starting to measure those as well. So data is important, and evidence. As I say, I leave out there with any researchers who are in the room. I think the most significant thing we could actually do is to turn the lens of research into saying, how do we know, what are the leading indicators for when somebody moves from ideation to intent, because we really need to help them then, and what are the leading indicators when distress and crisis is imminent. Let's stop the crisis before it actually happens. Workforce and community capacity. As I said, we all live in communities, and without putting a burden on community members or family members, frequently they will be the ones who will see those small but incredibly significant signs. One of the things I used to say when I went back into my eating disorders and in my mental health days is when parents or family members come to me and say, I'm a bit worried, I don't know if I should do something. God, have I learned over the years, do something. If you know somebody well and you're worried, there's probably a reason, and it's better to err on the side of that than not. So they're the enablers. And then what are the key shifts we need? As I've said, responding earlier to distress. Let's fix those points of distress. We fix the points of distress. Not only, hopefully, are we avoiding an attempt or a death, we're improving the quality of life. Let's go back to that first slide of mental health and well-being. We want people to thrive. That's fundamentally, we don't want to deal with illness. We don't want a medicalised approach. We don't want to have to solve the problems. Can we try and prevent the problems in the first place? So I think that responding to distress and realising the reality of that and the impact it can have on people is critical. Connecting people to compassionate services and supports. The two C's there, connecting, and I think assertive outreach is a critical thing we need to do. Connect them in to compassionate services and supports. Targeting groups that are disproportionately affected by suicide, I've mentioned that already. What are the very, very specific things that you can do in both serving times and ex-serving times that will make a difference? That will make a difference to reduction of distress as well as suicidality. And then delivering policy responses that improve security and safety. I think that's really critical. Again, this is the prevention lens. If we know, and let me take a very specific example or reference point here, if we know that for women transitioning from serving into X are twice as likely as the norm in general population to die by suicide, what can we do to make it safer? Not what can we do to help those particular women at that point of distress, that's critical. But what can we do in a policy sense to make it safer before that actually happens? There is a lot of work that's already being done, I think, in the defence area, and certainly when we were looking at what we were doing, we had reference to it all. Build on that. Build on it. And I would like to pay my respects in particular to the families and partner of Jessie Bird. I think that those and other advocates have made a real difference to bringing attention to this issue in a very pertinent, important way. I think there are some key areas, I think I've probably covered most of this, where you might like to consider specifically from a defence and vets perspective. Access to care and case management, I think that's well known. Taking support and services to people, I've been talking about that in a general sense. What does that mean for the Defence Force and for DVA? Most importantly, supporting them through those very well recognised transition and disconnection points. Collaborate. We need to look at how we collaboratively build out, not from your area, across the whole of government. And how can I have a slide without saying, ask people about lived experience? So let me just bring it all together. Lived experience, expertise, it's absolutely critical to everything we're doing, not only in suicide prevention, but mental health. A whole of life and a whole of system approach is necessary. My father's time serving in the Navy didn't finish on discharge. What he had experienced in the Navy, and he was involved in both of the crashes of the HMAS Melbourne, had a very significant impact on the whole of his life. And the whole of his life included his family and his friends, as well as himself. He died too young. And long-term sustainable planning to say, how can we actually change the system? So let's not rearrange the deck chairs, as they say. Let's actually change foundationally the system. I think that the opportunities presented through the appointment of Byrne as the Interim Commissioner, the wealth of her background, experience, expertise, the work that Gwen's doing and others, now is a time for real change. And I do believe we have not only a government that is interested, but governments. I had an opportunity to present the final advice to the National Federation Reform Council just before Christmas. The commitment's there. They just need some further help in understanding how to do it. Thank you.